This conference will now be recorded.
Hello, everybody, and welcome to this latest episode of the ACRM Pandemic Webinar Series. My name is John Morris, and I will be the moderator for this particular webinar. I'm a member of the Technology Networking Group within ACRM, and also a member of the ACRM Pandemic Webinar Series Task Force. And so if you're not a member of ACRM, please consider joining us. And if you are a member, please consider joining the Technology Networking Group. Today's presentation is titled Limb Loss Rehabilitation During the Pandemic, a Stakeholder Perspective on Barriers and Telemedicine. I'm pleased today, very much so, to introduce Dr. Prateek Grover, MD, PhD, MHA, and a Fellow of the American Academy of Physical Medicine and Rehabilitation. Dr. Grover is a board-certified PM&R physician currently on faculty at Washington University School of Medicine and medical director of the Rehabilitation Institute of St. Louis, Missouri. In addition to being a PM&R residency at Washington University in St. Louis, Dr. Grover has completed a PhD in biomedical engineering and a National Institute of Disability and Rehabilitation Research Fellowship at Marquette University. In addition, he has a master's in healthcare administration from Missouri State University. He approaches rehabilitation with the adage, alone we go fast, together we go far. Welcome, Dr. Grover. Prateek.
Thank you, John, for the introduction. Thank you, everybody, for being on the call and for the opportunity to talk a little bit today about something that is very close to my heart, limb loss rehabilitation. Who are the stakeholders, what are the barriers, and how has the situation changed with the pandemic, and how telemedicine actually plays an important role. Given the fact that there are many perspectives, this actually is part one of two talks, with the second talk on June 2nd. So thank you very much for being here one more time. The contributors for this presentation are from different disciplines. So we'll start with the patient perspective provided by Denise Hoffman. Tawnee Sparing is a physical medicine and rehabilitation resident at Harvard School of Medicine. John Felder is a plastic surgeon at Washington University School of Medicine, and I work closely with him and with Kirk, who is a certified prosthetist working as a clinic manager at Hanger Clinic. I have no financial conflicts of interest for this presentation. For the contributors, there may be non-financial conflicts that are related primarily to employment and to professional organization affiliations. So we recognize that rehabilitation services affect outcomes, not just for limb loss, but for all populations. So the local infrastructure, as well as the people around who are providing care, define how good the outcomes actually turn out to be. The COVID pandemic has created additional barriers to the ones that already existed. And these barriers are there not only for people who are diagnosed with COVID, but also for people who do not have COVID, such as folks with limb loss. And there is a strong need to address barriers, both pre-existing as well as the ones raised by the COVID pandemic. And some of the solutions out there include changing the infrastructure and promoting stakeholder coordination, which is what we'll be talking about in this webinar. The two major goals for this webinar include highlighting the pandemic-related barriers to care for limb loss rehab and discussing emerging solutions such as telemedicine to address these barriers. There are 5 main learning objectives. It always starts with understanding the patient's rehabilitation journey after limb loss. In usual care, it is important to understand how the infrastructure and stakeholder roles are defined. We'll describe barriers before and during the pandemic, and present from stakeholder perspectives how telemedicine is impacting their role in taking care of these folks. And then finally, it is important for participants to be able to take back some of this information to their local context and utilize it to improve their ability to provide care. So we'll be ending with that. The journey with limb loss and difference starts with the patient's journey. So let us take the example of a person who has had a foot wound and has been going to the wound clinic for many, many years. And they ultimately discover that wound care will no longer prevent an amputation. At the same time, let us consider another person who has a bone tumor and they require amputation as a life-saving surgery. So they discover that they need an amputation. A third case could be somebody who is born with congenital limb deficiency, so they have a limb difference. So that first phase is all about discovery. Once the amputation happens, folks require intense medical care, but at the same time, they also require rehabilitation to make sure they don't get deconditioned, that they learn how to take care of their leg, and the medical risk factors are minimized. They also may require some initial DME such as wheelchairs. Once the leg is healed, or let's say if it was an upper extremity amputation, the arm is healed, it is time to get devices for mobility and activity that include prosthetic devices. So that becomes the next stage in the journey. It is not sufficient to just receive these devices, but it is important to learn how to use these devices, where rehab comes in one more time. And then once that training is completed, it is important for folks to be able to go back to doing what they were doing before as much as possible. So it's not really the old normal, but a new normal at this point. As you can see, it's a rather long journey. And so if we look at the clinician perspective on that very same journey, because clinicians are taking the same journey with the patient as well. Dr. Eskenazi defined in a seminal article 9 stages or 9 phases of amputee rehabilitation. So if you think about categorizing them, the first 3, pre-op, amputation surgery, and acute post-surgical, primarily focus on surgery. The next 3 phases, pre-prosthetic, prosthetic prescription, and prosthetic training, focus on rehab and the prosthesis. And then the last 3 stages, community integration, vocational rehab, and follow-up, focus on community function. So what you start seeing are parallels with the patient journey at this point. The clinician is taking the journey along with the patient. However, in talking with some stakeholders, I found that these stages do not always capture everybody's journey. And so another way of thinking about the journey is looking at the health system and levels of care. So let us go back to a friend who required wound care. He was getting this on an outpatient basis, required an amputation, for which he went to the ER first, where it was determined he needed the amputation, went to the operating room, had the amputation, and was admitted either to the ICU or the floor. All of this is happening in an acute care setting. The person then went to an inpatient rehab facility to learn wound care and to make sure that they knew how to get their limb ready for a prosthetic device while minimizing the chances of reamputation. Once they left from there, they followed back in clinic with the physiatrist for prosthetic candidacy and with the prosthetist for fitting and designing the prosthesis. So that happened in the outpatient setting. Then they probably went back to the inpatient setting to learn how to use the prosthesis, or they may be doing outpatient therapy. And then ultimately, once all of that is completed, they're back in the outpatient setting, visiting the prosthetist or the physiatrist or the surgeon for ongoing needs. As you can see, this is a rather long journey. And these folks, both patients as well as providers, are touching the health system multiple times in 3 major settings: outpatient, acute care, and post-acute care. So just by looking at that, if you start visualizing how many folks are actually involved in this care team, it's huge. At the center, we always have the patient and the caregiver, because that is the focus. But if you start thinking of a very simple categorization of the folks who are required to participate along with the patient and caregiver in this journey, we can think about medical specialties. So if we pay attention to the triangle on the right and we look at the corners, the green color coding is acute care providers, post-acute care providers, and community providers. And the reason why I don't use the term physician is because it is not inclusive, because we have nurse practitioners and physician assistants also providing care in these settings. So it is providers that constitute the medical specialties. There are a number of other clinicians that participate in this as well. Psychology and therapy are great examples. And even though traditionally the prosthetic service is not considered clinical, in my mind, because of the fact that they help with taking care of the limb and with optimizing function, they are an integral part of the rehabilitation team. And so I tend to think of them as clinicians as well. And then finally, there is the non-clinician team, which is huge. So there is the advocacy and social support. There are folks who are helping with return to work, such as vocational rehab, return to driving, such as driving rehabilitation, recreational activities, and then we cannot exclude the insurance and regulatory bodies because they become part of the care team as well. So to summarize, before we actually start talking about barriers, we can think about a long journey that the patient and the providers take care together, as well as non-provider clinicians and non-clinical teams to facilitate care for this patient population. And as you can see, it is really complex. So it is not surprising that from a patient perspective, there are many barriers. The first barrier that patients describe is they do not understand what should be expected with regard to rehab services and with regard to the prosthesis. They also express personal challenges in being able to go through the continuum. They obviously have concerns about return to normality or normalcy. And in general, they have an uncertainty about the whole process. So looking at this from a patient perspective, you realize that we as clinicians may be thinking about certain things which may be distinct from what the patients think. So again, it is really important for us to integrate this journey. So the care continuum framework is not a new concept. It has been around for quite some time, and it actually helps integrate the patient and care team journey together. So just to explain this graphic, the arrow that you see really exemplifies the journey through the health system levels of care. And then the rectangles that you see in this case are really defining the patient and caregiver, and then the teams that we saw in terms of stakeholders on prior slides. And so when we start thinking about understanding what are the barriers, the first barrier that presents to us that we need to be looking at is what is the local infrastructure like and what are the things there that are posing challenges. The second is looking at team characteristics, and that number 2 that comes up is highlighted only for the patient and caregivers, but really applies to all the teams. What are the team dynamics within the team itself that may pose as barriers? And then finally, what are the interactions between these 3 teams? So the reason why the arrows are in red is to highlight that oftentimes there is not enough communication or interaction established, and there requires to be formal effort to do this. So while the COVID pandemic poses certain barriers, it also actually gives us the opportunity to utilize novel solutions such as telehealth. And telehealth has the ability not only to facilitate improvements in infrastructure, but also to improve coordination between all the teams. So with that, I would like to present a brief background on telehealth regulations during the pandemic and how they apply to providers. So what is telemedicine? So this started with the Office of Civil Rights Director talking about empowering medical providers to serve patients wherever they are. And so telehealth services were defined to include audio, text messaging, and video communication. And OCR said that they have not defined a timeline when telehealth will go away. So it may be a great opportunity, especially if it continues. Now, who is covered? So HIPAA defines a healthcare provider as a provider of a medical or a health service not just a person, but also an organization. And this includes, but is not limited to, physicians, nurses, clinics, hospitals, home health aides, therapists, other mental health professionals, dentists, pharmacists, labs, and any other person or entity that provides healthcare. So it is currently a rather broad definition, which I think is great because it allows us to integrate stakeholders into this journey. Now, what is covered? Again, it's a very broad definition, and it states all services that a covered healthcare provider in their judgment believes can be provided through telehealth. It includes not only COVID-19 related conditions, but also non-COVID conditions, which applies to our patient population. Ultimately, it is important to consider sustenance. How will a hospital or a clinic or a provider who's providing services sustain? So it is important to figure out who the payer is, and the 1135 waiver has allowed the expansion of telehealth and states that Medicare can pay for office, hospital, and other visits furnished via telehealth across the country, including in patients' places of residence. And this started about 6 to 8 weeks ago. March 6th is when this started. So the definitions, they again specify it includes doctors, nurse practitioners, clinical psychologists, adds to the list clinical social workers. So as you can see, it's a non-inclusive or a non-comprehensive list at this point, which is rather broad. How do we provide the telehealth services? So public-facing products, and these basically are things like chat rooms. They are not acceptable. This is because they violate privacy. On the other hand, non-public facing remote communication products are allowed, and most of these are available on our phones: Apple FaceTime, Facebook Messenger video chat, Google Hangouts, WhatsApp video chat, Zoom, and Skype. They also add that texting applications such as Signal, Jabber, etc. are included as well. And the reason why this can be done is because of end-to-end encryption, which allows both the person sending the call and the person receiving the call to control what is transmitted. There is a higher level of security that can be achieved using what are called as business associate agreements. And examples include Skype for Business, Zoom for Healthcare, and things of that nature. So the question really that it comes down to is, should we be using non-public facing remote communication products or these BAAs? And so the good news for providers is that OCR says it will not impose penalties against covered health providers that we talked about as rather broad if they do not use a BAA, because a BAA is oftentimes difficult to get at something that larger organizations are using. It will also not impose penalties against any health provider, even if they are not in compliance with HIPAA rules, as long as the service was provided in good faith. So that gives us, as providers, a lot of confidence in our ability to provide services for people without being concerned as much as we would have been in normal course about getting sued for something that we did not intend to do, which I think is a very important point in regards to empowering providers. So with that, I would like to turn over to the perspectives that have been provided to us from the different stakeholders to understand what are the barriers before COVID, currently with COVID, and how telemedicine is helping. So Denise Hoffman is a transfemoral amputee of many years who has been extremely active and has made major contributions to this field over the past few decades. She's a certified peer visitor, a legislative lead advocate for the limb loss community, works with Freedom Innovations, Amputee Coalition, American Orthotic and Prosthetic Organization, and also with the ACRM. So she is extremely active, very passionate about working in this community. And the following perspective is hers and gathered from the other patients that she has talked to as a peer visitor. The most major impact that she identifies is on mental health. So we recognize that social isolation is a pre-COVID issue. We also recognize that home restriction in general limits participation. What has happened with COVID is that peer mentorship, which is basically traveling to folks, being able to talk to them, counsel them, discuss things with them, in other words, enable them, has come to a standstill. Support group meetings that were organized on a regular basis have been cancelled or they have become virtual. And then in the elderly folks who are not technologically proficient, they're not able to use telemed services as much as some of the others. And so overall, there is much more isolation. And if there is not good family support, mental health is impacted directly. Physical health is impacted as well. So prosthetic abandonment is not a new issue. It's a pre-COVID issue. Folks will not use their prosthetic device if the energetic requirements are too much. And sometimes they will discard them completely. Now, with staying at home, what has happened is that people are not doing as much physical activity and they're not using their prosthetic device as much. So the risk of prosthetic abandonment actually increases. Virtual therapy has been helpful because virtual therapy, still in its infancy, is actually starting to encourage activity at this point. People are beginning to do more at home, especially if they're able to get in touch back with their therapists and things of that nature. But it is not a substitute for in-person therapy. Gait training and things of that nature are very difficult to do if it is not somebody in person. From a system and patient perspective, there are barriers to care. So when it comes to medical care, there is recognition that elective surgeries, or what are defined as elective surgeries, pretty much stand cancelled. From a patient perspective with social distancing, there is hesitation for in-person visits. The same thing applies for prosthetic care. So limb loss appointments have been delayed. Patients are hesitant to go for in-person visits, which is understandable. When it relates to therapy, it's the same story. In-person clinics stand cancelled. There is probable resumption that I've heard about in the next few weeks that may be happening in certain parts of the country, where some in-person therapy gets resumed. So that'll be hopeful. But currently, in-person clinics stand cancelled. And virtual therapy, as we mentioned, may have limited utility. However, telemedicine is something that is here to stay. So Denise has formulated this wonderful cheat sheet that I'm going to mention briefly, where she's got 4 steps for a patient to attend a telehealth appointment. The first is defining requirements. The first step there is that these appointments are intended for elective reasons only, not for an emergency. It is important to verify coverage with insurance and to sign the consent form with the provider. The requirements include an email address, adequate internet capabilities, a device that has audio and video, and knowledge of the provider telehealth platform, which may require folks to download an app. Also requires or may require for certain folks assistance with technology, and if privacy is desired, headphones would be a good thing to have. So once all of these are met and a patient is preparing for a visit, it is important to write it down. Write down the reason for the appointment, have the questions ready, and make sure that you have a prior health history, list of current medications and allergies, as well as the name of the pharmacy and phone number. The next step is setting it up. And to set up for a telemedicine visit, it's important to have a quiet space, block out appointment time, dedicate a device for receiving the call, ensure a good charge on the device. And I found this very interesting. Which I think goes above and beyond, which a lot of places may not be doing, which is have pertinent medical equipment handy for the visit, such as a thermometer, a blood pressure machine, a spirometer, and a glucometer. And then make sure that you pre-test your video and audio. Now, once all of this is set up, during the appointment, it is important to write down pertinent information, clarify what is not understood, verify that the written questions have been answered, and then verbalize the understanding of the plan, including the next appointment. So from a patient perspective, I think this is really comprehensive, and from a provider perspective, I think this is really useful. If the patient had all of this ready, this would be a fantastic visit. Now, with that patient perspective in mind, I would like to turn to the provider perspective. And I would like to start by providing you with the resident perspective that has been contributed by Dr. Sparling, who is a resident at Harvard School of Medicine in the 3rd year for physical medicine and rehab. So physical medicine and rehabilitation is a rather small field. If you look at this graph on the right hand side, just about 1% of patients actually go into PM&R. 1% of physicians go into PM&R, sorry. During the pandemic, there are three major rules that the residents have. The first is that some of the folks are diverted to acute care. The second is that they are still within scope of practice pre-COVID, which is that they are in the inpatient rehab setting or on consult. The third possibility is that they may be, like some other folks, working from home. So what the pandemic has done is disrupt bedside training. Limb loss rehabilitation is a small field to begin with, and what COVID has done is decrease the number of amputations because the surgery has been affected, and so the number of people coming to inpatient rehab has been affected. The other reason, which is interesting, is that most of the people are staying inside at this point, so hopefully there are fewer traumatic events and we are seeing lesser traumatic amputations. And then we recognize that we are not admitting as many people from home at this point, therefore prosthetic rehabilitation is on hold. So in other words, there is need for additional education during this pandemic so that residents don't miss out on what is already a very specialized field. And telehealth is actually great for bedside training. We do this in our setting as well. The best way to do this is to actually discuss the case with the resident beforehand. Make sure that during the patient visit, if possible, include them using telehealth for physical exam, history taking, and things of that nature. Make sure to discuss with them clinical pearls, and then finally also continue to discuss articles of interest. And then while strictly not telehealth, virtual resident education has really taken off. And there is a lot of material available at this point to residents, both for structured didactics and for self-directed learning. It still doesn't take away the role of the attendings to make sure that they're involved in this training so that residents can make the best use of their time. And remember that these residents are the future for taking care of the patients with limb loss. So I think this is a really important role of telemedicine. Next, I would like to talk a little bit about the surgical perspective presented by Dr. John Felder, who is a plastic surgeon at Washington University School of Medicine. He, I, and Kirk Pills, whose prosthetic perspective will present at the end, work together. So a lot of things that you hear from here on are combined perspectives. So when we look at pre-COVID barriers from a system perspective, there is limited understanding of the local system. There is oftentimes a fragmented link between wound care and surgery, which I think is a very important link. From a patient perspective, barriers include barriers to access because of things like socioeconomic factors, access to primary care, transportation, and things of that nature. But also, in addition, there is limited knowledge. From a provider perspective, not all providers have the same level of knowledge about amputations and care that follows amputations. And then there is a question that has been there for a long time and still continues to be a question that different stakeholders have different answers to, and that is, what are the decision factors for amputation? At what point in that journey, in that patient journey, do we actually go ahead with an amputation? So these are the major barriers. Of course, there are many others, but these are some of the major ones that stand out. And ongoing work at Washington University School of Medicine before the pandemic hit included the following. So at the system level, we had started studying local system resources, and we had started forming a multidisciplinary institutional coalition between trauma, plastic surgery, physical medicine and rehabilitation, orthopedics, wound care, prosthetists, therapists, and things of that nature. So it was a rather large coalition that we had started working on at the institutional level to start addressing some of the system barriers. From a patient level, we had started studying barriers to care and also developing patient education and materials. From a provider factors perspective, there's a strong focus on provider education. And a great example of that is the ACRM instructional course on advances in limb loss rehab that would have been held at the spring meeting, but had to be cancelled because of the pandemic. but has been accepted for the fall meeting. So folks on this call, if you're interested, especially in learning more about limb loss rehab from a multidisciplinary perspective, it's a good course to attend. So we had started working on provider education, and then the research focus was on looking at limb preservation and restoration. Now, when the pandemic hit early in the year, the multidisciplinary institutional coalition was delayed. In the OR emergency cases, as we mentioned before, anything that was counted as elective or semi-elective was cancelled, and clinic had to be closed temporarily until telehealth services actually started up. And so fast forward a month or two, and we have utilized virtual meetings to restart the institutional coalition. There is very gradual resumption of cases that are not technically emergency, it's rather slow. And in the clinic, telehealth has started up. So from Dr. Felder's perspective, it is a good thing to have for follow-up and prescription, but it is still limited because if he cannot do a follow-up revision surgery, which may be counted as semi-elective or elective, he's not able to help the patient to the extent that he would like. Once the surgery is done, it's basically PM&R that takes over to a great extent. And so from my perspective, my journey with the patient focuses on five different levels. The first is consults, and during consults, it is time for PM&R physicians and for the prosthetists to go talk to the patient, make sure they understand everything that is going on, and facilitate transfer to pre-prosthetic rehabilitation. As you can see, the volume of patients that comes over from consults to pre-prosthetic rehabilitation decreases because some of these folks will either go to a skilled or they'll go home. Now, once they leave from the rehab hospital, some of them will come back for prosthetic prescription and a percentage will not. Once they get the prosthetic device, an even smaller percentage will come back for prosthetic rehabilitation and other folks will not. And then finally, once folks have completed the prosthetic rehab, they're back to the new normal, and even smaller percentage comes. So as you can see, where the physiatrist is involved, over time, there is a decreasing volume. So it makes me wonder as a physiatrist, who are the people who are not getting care that they actually need? So with COVID coming in, consults did not really decrease much. The volume of patients from consults to pre-prosthetic rehab did, because remember, the number of surgeries went down. But everything beyond that, prosthetic prescription, prosthetic rehabilitation, and prosthetic follow-up, everything stopped. And so over time, rehabilitation services have adapted, consults have stayed, pre-prosthetic rehabilitation has been facilitated by telehealth, at least to some extent, where we are including our residents in resident education, and for folks who are immunocompromised from the provider perspective, are still able to visit with their patient using telehealth in the inpatient setting. And then prosthetic prescription and follow-up have resumed in a smaller volume, and it's building up, and I think it'll build up really well. But again, it is facilitated to a great extent by telehealth. Prosthetic rehabilitation, which is admissions from home, has still not resumed, and this relates to inpatient rehab not accepting admissions from home and outpatient therapy clinics not doing inpatient rehabilitation either at this point. So I would like to tie that in with the prosthetist perspective, which is contributed by Kirk Pills, who's working closely with the team at Washington University School of Medicine. He's the clinic manager for Hanger Clinic, and he's extremely passionate about the work he does. His work includes not only managing the clinic, but also training ONP residents and PM&R residents, and I believe he started working with plastic surgery residents at this point as well. So he brings a breadth of experience and thought to this discussion. And there are three major perspectives that he has. Now recognize that he works as part of Hanger Clinic, which is a chain of ONP services across the country, which means that his perspective may be a little bit different from a standalone prosthetist perspective that will be presented as part 2 of this webinar a month down that we'll talk about at the end. But his perspective is really valuable. So if we look at the table here, this table basically talks about prosthetic appointment types. What was the clinic doing before COVID, and what is the clinic doing now during COVID, and what it might do after COVID as well. And so the type of appointments, if we think about somebody who's getting a new prosthetic device, include evaluation, casting and measurement, check socket fitting, definitive fitting, follow-up, adjustment, and provision of supplies. Before COVID, everything was in clinic. After COVID has happened, things have been modified. So the initial evaluation actually is a remote consultation. The casting and measurement, check socket fitting, and definitive fitting has to be in person, so it happens right there. And then follow-up, adjustment, and provision of supplies can again be done remotely. The second piece is coordinating prosthetic prescription. So pre-COVID, it was an integrated practice clinic, which means the physiatrist and prosthetist were present in the clinic. They met with the patient. It was rather collaborative. There was a huge focus on patient education that included gait analysis, symptom management, medical risk, referrals, talking about the choice of components and why, the need for rehabilitation, inpatient versus outpatient and why, and then definition of future visits. So a typical visit would take anywhere between 30 to 60 minutes. But it was a good visit because there was great coordination. And then the visit ended by setting up appointments for the rehab clinic for any inpatient rehab that may be required with the prosthetic device and independent prosthetic clinic appointments. With social distancing and stay-at-home orders, obviously the process has changed completely. So there are two workflows. The first workflow talks about the physiatrist sharing the clinic schedule with the prosthetist. The prosthetist shares the last patient evaluation back with the physiatrist. There's an independent virtual patient evaluation by the physiatrist. And then once this is completed, the physiatrist and the prosthetist discuss the plan, and then the prosthetist schedules any patient visits. The other workflow, which we have been trialing, is that the physiatrist shares the clinic schedule with the prosthetist. It is the prosthetist that actually schedules an in-person appointment with the patient, which means that the patient actually goes to their clinic, which they would have done at the end in that last workflow. While the patient is in the prosthetic clinic, there is a virtual patient evaluation by the physiatrist. So this is similar in concept to the original visit, except that the patient and the prosthetist are present together, the physiatrist is remote, and then a collaborative treatment plan is established. So there are benefits to both, and there are negatives to both. The first one has a lot of background work, but it is very simple in concept. It utilizes telemedicine basically by the physiatrist. The second one is a little bit more complicated, does require the patient to travel out early rather than late, but it's a more comprehensive visit. So both workflows are being trialed. They are early in the stage, so it'll be interesting to see which one actually becomes more successful from a patient perspective, a prosthetist perspective, and a PM&R perspective. The third piece is prosthetic approval. So before COVID, the prosthetist would evaluate, the physician would document and prescribe, and then the prosthetist would code. And certain elements of documentation were crucial to getting the prosthesis on the right time without delays, which included a patient desire to ambulate with the prosthesis, comorbid conditions influencing patient's ability to use the prosthesis, prior and current functional level, expected functional level, and then finally physician and prosthetist agreement. So the documentation itself is rather intense and requires good coordination, which an integrated clinic visit actually facilitates well. Now, what has happened since then is that CMS has theoretically, in an emergency, relaxed documentation requirements for lost, stolen, or irreparably damaged devices. However, Kirk says that guidance on implementation is still in process, and it is still important to seek detailed documentation. So no changes to process as far as that is concerned. The good thing that he shares is that time for authorization, at least for his clinic, has not increased. And he has not found any increase in denials either. Again, this may be a little bit different for a standalone clinic as opposed to a hanger clinic, but the overall message that we have from hearing these three perspectives is that telemedicine is a good thing, and COVID may actually have given us the opportunity to expand on this more. So I mentioned at the beginning, the fifth learning objective really was take-home strategy. So I would like people who are listening to this to try and implement this in their local setting. And there are three major themes that unify stakeholders, and I would recommend trying to do all of these simultaneously. The first is coordinating the care infrastructure. If you're a physician, talk to your therapist, talk to the prosthetist. If you're a therapist, talk to the other members of the team. Make sure that you're able to coordinate infrastructure as well as possible.
Okay.
The second,
Dr. Grover,
hello, can you hear me? My apologies.
Yes.
No
problem.
The second theme is patient and provider education. So make sure that you focus on educating not only the providers, but also patients. Develop robust educational materials. And then the third piece is patient and caregiver participation. So I think it's really important to utilize telehealth, to make sure that you get your peer mentor, you get your advocacy group together, you hold community virtual meetings at this point to get the patients, the providers, and other folks together. This conversation is ongoing. Obviously, there are many more perspectives. So the part 2 of this conversation will continue on June 2nd, and we'll be presenting therapy, organization, and association perspectives. And the contributors, just to highlight, will include Debbie Latour, who is an occupational therapist and an upper extremity amputee, and she has done some major work in the field. Dan Ignazewski, who is the Chief Policy Officer for Amputee Coalition, Lisa Chabonneau and Mark Dwyer, who are in the administrative role at Encompass Health, which is a chain of over 130 inpatient rehab hospitals and home health services. So they have a very interesting perspective from the organization side. Jim Weber and Ashley Wyatt from the American Orthotic and Prosthetic Association. And then I will tie it up as part of what ACRM's Limb Restoration Rehab Networking Group is doing to keep this conversation going by including all stakeholders. I would like to end by saying that it is only together that we go far. Thank you very much for your time.
Excellent. Thanks so much, Dr. Grover. That was really fascinating. I invite the attendees to post questions or comments in the chat field in the lower right of your screen and post to everybody. And I think I will kick off this Q&A session, if you don't mind, with a couple of questions, Dr. Grover. First of all, thanks again for the wonderful presentation. I was really impressed. Of course, it's perhaps not a surprise to anybody in the rehabilitation field to see just how complex the patient journey really is. It's multi-layered, multi-step, lifelong in the end, and includes multiple specialties. And so you pointed out, I think, and made the point very strongly that this journey is full of uncertainties for the patients and probably also for providers as well to some degree. And I guess my question is that, given that we've been forced into sort of, exploring new methods of interacting with the patients and communicating and providing service, what do you think will be the broader impact of the pandemic for promoting a rethinking of the patient's journey, and particularly, I guess in this case, the patient's journey for limb loss and rehabilitation? And then the second part of that question is, I guess it's the same question. What do you think will stick? So where are we going in the short, medium term, and what will the longer term implications of sort of responding to the pandemic do? What are those for your field?
So great question. Thank you for actually bringing it all back together. So if we just look at the journey, we see it is extremely long, and we see that a lot of it requires touching back with the healthcare system again and again and again. So the pandemic has certainly created mental health issues, physical health issues, but it has also given us the opportunity to rethink the journey, to rethink some of the things that were basically beginning ups. And telemedicine is a great example. So we recognize that it's not a new thing. We recognize that with HIPAA limitations and with the cost of actually having robust telemedicine systems, things were much slower before the pandemic, but a lot of organizations were beginning to head into that direction. The pandemic has given opportunities to people to actually accelerate that time course. And I think telehealth is here to stay. My department has actually reached back and said, we don't think it's going to go back to exactly the way it was. How much of it will stick is a difficult question to answer. But I think just seeing the benefit that telehealth has, I think it is around to stick. With regards to specific phases, telemedicine is a great substitute for things like certain patient visits, which are limited in terms of their scope. So if somebody is staying 2 hours away, for them to have to come back for a simple prosthetic prescription that is not a new prosthetic prescription is something that telemedicine can take care of remotely. If it is liners that are needed, if it is a socket change that is needed, some of the simpler things. If, on the other hand, it is a surgical evaluation, telemedicine obviously cannot play that role. So I think there is going to be a balance that gets created, but I think it's time for us to remember that ultimately it's about taking care of the patient, and we should be utilizing all the resources that we have and the opportunities that have been offered to us to continue this journey.
Great, excellent, excellent. Well, I see we have a question from Tawnee Sparing. Which parts of the physical exam have you integrated into your telehealth visits, both when the prosthetist is and is not present?
So basically, the prosthetist can serve as a proxy for almost the whole physical exam if they are present with the patient. Range of motion, evaluation of contractures and things of that nature can be done without the prosthetist being present, but there is not a substitute for palpation, there is not a substitute for tenderness, and there is not a substitute for taking measurements. It is very difficult, I think, to train a patient to go ahead, identify their own landmarks and take their measurements, which becomes a crucial piece of prescribing prosthetic devices. So I think those workflows are an evolution, but again, to highlight the point that the prosthetist is a vital part of the care team, and really having the prosthetist and the patient present together just changes the whole paradigm of being able to take care of the patient.
Super, thanks for that. So I have to say, somewhere in the middle of your presentation, you showed several slides that showed kind of a cheat sheet for telehealth visits, and I thought that was brilliant. And as a side note, I would encourage you to maybe try to find other ways to share that across other disciplines and other, people serving other, patients with other diagnoses. I thought it was really highly useful, but it prompted several questions about our current, electronic existence, right? On a given day, today we're on GoToMeeting right now. Probably earlier today, some of the attendees here were on a Zoom call or a Skype call or a Teams call, and we've got cameras and microphones, et cetera. And so there's quite a bit of sort of, both the technical side and also the if you will, the process side that was also illustrated in the cheat sheet. And I'm wondering if you've encountered among your colleagues, your limb loss and rehabilitation colleagues, and maybe others, where you work, on the provider side, but also on the patient side, like resistance or lack of enthusiasm. And when you really need to deliver a service, then what do you do in those cases? And I think the third part of that question is really about training. So that cheat sheet was brilliant, but it seems like maybe some more training may be needed. So 3 questions, do you encounter resistance? What do you do in those cases? And then also kind of separately, do you provide training for patients or clinicians?
Great questions again. I would actually like to start by thanking Denise Hoffman for creating that cheat sheet, because I agree with you. I think it is brilliant. Do I encounter resistance to the use of telemedicine? The answer to that is yes. So our outpatient visits are scheduled such that we can actually have a video encounter or a phone encounter. There are certain people who do not want to use video. So we have a phone encounter that does limit our physical exam almost completely, at least in certain domains. So one can assess the cognition at least to a certain extent based upon the conversation. One can potentially extrapolate mood and some other things. One can ask the patient to move their arms about, move their legs, and you can document a functional exam. But you cannot document manual muscle testing. You cannot document tenderness. So there is resistance if people don't have access, but I think with the government giving us permission to be able to do that, I've changed my documentation to reflect my limited exam and yet try to provide the care that is needed. So I've done a prosthetic prescription using that because I was able to use the prosthetist notes talking about that first workflow that they provided, which said that a week ago when they had seen the patient, there were no wounds. So using that information, I prescribed a prosthesis. Video visits go really well. Uh, so I haven't encountered any trouble with that at all. So overcoming the resistance obviously is difficult, but I think we have to cater to the fact that we recognize this in medicine in general, that patients are different, and we have to include patient preferences in our ability to take care of them to be able to provide the best care. Training with regards to that cheat sheet, I think, is a great idea. And I appreciate your thought that we should be sharing with other patient populations. I think that is a fantastic idea as well. So I will certainly make it a point to bring it up with our folks in the department who actually are the ones consenting the patient. I think this would be great.
Super. And I guess related to that too is this kind of a question of health literacy and understanding. Probably some patients have sort of lower reading levels, lower sort of comprehension, et cetera. And maybe with virtual, visits, et cetera, those may impose a kind of a greater cognitive burden on patients. How do you sort of address that, or can you elaborate on possible additional challenges to patient education, health literacy, et cetera, when relying more on telehealth?
That's a very valid point. So I think there will be limitations going forward with the level of literacy and things of that nature. Just like there are limitations, I think, for people who are living in rural areas and don't have access to specialists. So one possible far-fetched idea, but given the fact that we are doing things very differently than we were doing 6 months ago, it may not be as far-fetched, is looking at the analogy that systems of care such as the Veterans Association or VAMC offer, where they actually have a relatively integrated system across the country, where if you're living in a rural area, you go to a primary access point. If you need more care, they refer you up the chain all the way up till the highest tier. So it is not impossible to envision a similar system where one could possibly coordinate with the patient's primary care, and maybe they don't come to visit you if they are a few hours away, but they go to their primary care, and you're able to coordinate your visit in that fashion. The other thing to think about is simplifying what we have defined as far as that handout or cheat sheet is concerned, maybe even making it more pictorial, just a couple pages, and utilizing that as something that could go out. The third possibility is actually some of the stakeholders, such as the prosthetists or the peer visitors, once things resume, talking more about this and integrating this as part of our regular conversation.
Excellent, excellent. Well, I think we would be remiss if we did not address the issue of abandonment. I know that's a big issue in your field, and of course, and elsewhere in rehab, just abandonment of assistive and accessible devices, et cetera, is huge. And so you mentioned it towards the end about, the fact that in the current environment that patients who are already perhaps already prone to be socially isolated or have even less social interaction and less opportunity to go out and be with others, et cetera. And that this may then cascade into sort of basically lower perceived need for the prosthesis, and then ultimately possibly abandonment entirely. I wonder if you could just comment more broadly on, if that's what you think you may be seeing. I know it's early on, and what the professionals in your field can do to sort of attenuate that sort of tendency.
So prosthetic abandonment, as you said, is an age-old issue. It's not new, and there have been challenges already to it, especially depending upon demographic factors, patient factors, and things of that nature. The pandemic has obviously exacerbated some of those things, but I think with gradual resumption over time of at least some of the in-person services, I think we as a field, especially stakeholders, have to coordinate more with each other and include patients in more conversations in regards to getting them the prosthetic devices. We at the same time have to work with the insurance companies to make sure that they don't perceive this in the wrong fashion and perceive that if a patient could manage without a prosthetic device during the pandemic, they can possibly manage with it without it later. So I think it's a multi-pronged conversation that really goes and stretches across the whole spectrum to be able to make sure that we are actually able to get folks with limb loss motivated enough to continue their work with the prosthetic device. We keep the prosthetists and the physiatrists and the surgeons involved in the care to make sure that we are actually able to optimize some of the outcomes that we talked about early, and address some of the pre-COVID barriers to care, which have still not gone away. And then at the same time, at the end, at the distal end, address and continue to talk with CMS and continue to talk with other organizations to make sure that prosthetic device prescription rates and approvals do not go down.
Excellent, excellent. Well, I think we are close to being out of time, so I wanted to thank you, Dr. Prateek Grover, for your presentation today, and we very much look forward to your follow-on part 2 on June 2nd, Tuesday, coming up fairly soon. And I will advise the attendees that the recording for this session will be mounted on the ACRM website and ultimately to YouTube within 24 hours. Again, Dr. Grover, thanks so much for your informed and fascinating presentation, and we look forward to talking to you in about a month.
Thank you, everybody. Be safe and be healthy.
Thank you. Bye.